Hello, everyone, and thank you for joining us today for today's session on building better kidney health advocacy, mapping the lived experiences of people with chronic kidney disease. My name is Ryan Woolley, and I'm the Senior Director of Public Education at the American Kidney Fund. The American Kidney Fund has partnered with the National Health Council on a research project that will provide key insights from the experiences of people with chronic kidney disease, including those who crash into dialysis, to better elevate the urgent need for awareness and help inform the development of evidence-based, patient-centered resources. And so we're joined today by Lillian Whitting and Silke Schock from the National Health Council to discuss this project and how understanding the lived experiences of people with chronic kidney disease can help providers deliver better healthcare services and encourage patients to speak for their health. So I'll go ahead and introduce both our speakers. So first we've got Silke Schock, who is the Director of Research and Programs at the National Health Council. Ms. Schock joined the National Health Council in 2017 and has managed many of the NHC's patient engagement focused projects, including the Patient Experience Mapping Toolbox, the Patient-Centered Core Impact Sets Blueprint, and Patient-Centered Value Classroom. Her interests include patient engagement, qualitative research, and gender equity research. She has published in The Patient and Value in Health. Ms. Schock earned a Bachelor of Arts degree in International Studies from American University in 2017 and a Master of Arts degree in Public Management from Johns Hopkins University in 2023. Thanks for joining us. We're also joined by Lillian Whitting, who is the Senior Coordinator of Research and Programs and joined the NHC in 2022. Since joining, she has leveraged her background in climate health advocacy and food accessibility to provide perspective on various projects that emphasize meaningful patient engagement within the healthcare ecosystem. Her focus lies primarily on qualitative research with the goal of translating science into policy. Lillian earned her Bachelor of Science in Global Health from the University of Arizona and a Master of Public Health and Environmental Science and Policy from George Washington University in Washington, D.C. And before we get started, I want to encourage everyone joining to please type your questions and comments into the chat box on the right of your screen. We will try our best to get all of your questions answered during our Q&A segment at the end of this webinar. And now I'll hand it off to Silke and Lillian to lead us through our next portion of the session. Silke, the floor is yours.
Well, thank you so much for including us today to discuss patient experience mapping with chronic kidney disease patients. As you noted, I'm Silke Schock. I'm the Director of Research and Programs at the National Health Council. So my work focuses really on how to foster meaningful patient engagement with communities, working with the patient community to create novel research methodologies that showcase their powerful voices. So that's something that we're especially interested in. But just to give a little more background about the NHC, the National Health Council is a nonprofit that represents patients with chronic diseases and disabilities in the U.S. We're over 100 years old. So here's just a snapshot of some of our patient organization members. Of course, the American Kidney Fund is a member of ours and was instrumental to this project. So thank you. We couldn't do it without you. So today, I'll be kicking us off with a short introduction of what the methodology behind the study was, just to level set us a little bit. And then my colleague Lillian Whitting will dive into the study we conducted with chronic kidney disease patients. And then we're going to review the preliminary results of the study. So the analysis and final interviews are still ongoing, but you guys are seeing a little sneak peek of what this research has shown us for your community. So we can go to the next slide. Great. So the NHC used the Patient Experience Mapping Toolbox to conduct this study. So how and why was this tool created? We created this tool to capture patient experience data holistically across the lifespan of a patient's journey. You can see here the definition of patient experience data. It's really any data that discusses the impact, including physical and psychosocial, of a disease or condition, or related to the therapy or clinical investigation, and then patient preferences with respect to treatment of the disease or condition. So really, anything a patient tells us is patient experience data. It's extremely important. Collecting patient experience data was outlined in the 21st Century Cures Act of 2016. This act directs the Food and Drug Administration to report on the use of patient experience data in regulatory decision-making, especially focusing on the review of how it was used in patient-focused drug development tools as part of any applications for treatment or anything like that. So we created this toolbox as a set of resources to look into patient perspectives on their lives from the whole disease trajectory, from before they got a diagnosis, when they were just experiencing symptoms, to when they sought a diagnosis and what they went through when that happened, to what are their lives like today as they're living with a diagnosis. You can go to the next slide. Thank you. So this toolbox was developed by researchers at the NHC. It's disease agnostic, which means it can be used for any chronic disease. Of course, Lillian will talk a little bit more about how we adapted it for the kidney disease community. We had a wonderful group helping us with this, including the American Kidney Fund. But this work is essentially a bank of qualitative questions and tools that are used to interview a patient for 60 to 90-minute interviews. It was originally pilot tested with 30 patients. We also had 5 cognitive debrief interviews where we really went through every single piece of the language used in the interview guide. The interview guide is about 41 pages, so it's kind of long, but it runs the gambit, through different things that a patient can experience: non-medical, medical, treatment, insurance, finances, nutrition, emotional health, mental health, discrimination, bias, stigma. So, it asks every type of question we could think of about a patient's life and how their disease affects it. But I do want to mention that the patients in the pilot study really designed, produced, edited the interview questions and the accompanying patient-facing visuals. So I really love this methodology that we use, because it was created by and for patients. The advisory board that assisted in creating this work was also a majority patients and patient advocates. And a patient on the advisory board actually created the term patient experience mapping. So really in-depth work with the community there, which I love. So this toolbox is customizable to a variety of conditions and demographics. It was reviewed by a third-party health literacy firm. Health literacy is extremely important to both the National Health Council and I think any work in the patient engagement space. It really makes it so that the toolbox is, one, easy to understand. We try not to use too much medical jargon. And even the researchers like the health liter version more than kind of the more clinical version that we first created. So it's great to see that it has such a high benefit and use for everybody in the study. We can go to the next slide. Thank you. So here you can see an overview of the resources in the PEMT. It's kind of separated into 2 components: the project planning tools and the data collection tools. So the project planning tools are tools for project coordinators, project managers, and the team. And it looks at, how do you conduct an interview? How do you create a study? What is the best way to do that? What is an IRB? What is an institutional review board? Why do you have to seek IRB approval to do a study, things like that. So if you've never done a qualitative research study before, especially with the patient community, I would say the project planning tools are a fantastic place to start. They were reviewed for health literacy as well. So they're a really good way to kind of get caught up to speed if you're looking to do a project in that space. We also have data collection tools. This includes the interview guide template. That's the one I mentioned. That's 41 pages. It's a bank of qualitative research questions that were validated and piloted with various patients. We also have an accompanying map my experience visual. This is what the patients will see during the interviews. We usually do these interviews over Zoom, so the patient would be seeing it on a screen. And this is just so that we can reach an audience that's diverse in terms of geography. But it can also be used in person, so a patient can look at it. It's printed out. We have done focus groups where it's been used printed as well. And then we have our consent sheet template. I also love the consent sheet template because this can be customized to any study. It's also great for any patient organizations to use for their work and can be adapted to different types of qualitative work. I think something that's important to note here, it's in very, very small font between project planning and data collection. We have listed here our patient compensation toolbox. This is a toolbox we created that helps organizations determine a compensation range to pay patients who are involved in patient engagement activities. So it gives you, it's a calculator where you put in how many hours you would like a patient advocate, or caregiver to do a patient engagement project. And for us, this is any co-leadership and any research. So not where patients are subjects of research, but where patients are co-leading in the research or creating qualitative information, like for a focus group, interview guide, speaking on a panel, being on an advisory board, things like that. So this compensation toolbox we use for all of our studies. It's very important to pay patients involved in patient engagement work for many reasons. They're the experts in their condition, and we should pay them as experts. So something I always want to mention, very important, and we did compensate, of course, patients for this work as well. So next we have an exciting slide. I just wanted to showcase an example of what the health literacy review looked like and why it's so important. So here you can see a side-by-side example of what our first consent template looked like, and then the health literate one on the right. I know the font's a little small, but you can kind of see in a general overview that the fonts, colors, white space, even the type of language that's used in the text make it so much easier to read on the right-hand side. The left-hand side, looks like one you'd receive from a clinical study or something like that. It's a little harder to read. It's like, where do you focus your eyes? But the one on the right makes it easier to go through in a linear fashion, see what's important, see what you need to know. So this is just an example of kind of how it looked before and after it went through health literacy review. And I did mention this before, but that was conducted by a third-party firm that's also a nonprofit working in this space. So lots of engagement from the community to publish this work. So on the next slide, this is an exciting one. We have here our Map My Experience tool. So this is the patient-facing visual. This is what they're seeing during the interview. And I know some of the details are hard to see, but it's essentially divided into 3 islands. So we have life before getting a diagnosis, getting a diagnosis, and living with a diagnosis. We have a straight highway type of road, and then a long winding path. As you can see, there are also several other visual prompts. There's mountains and lightning. There's information gathering booths. There's places where patients can talk about lifestyle changes that they made. Maybe they stopped smoking or took up yoga or something like that, or something for stress relief. You have clinics where they can talk about what happened when they sought care, pharmacies. It runs the gambit. You can also see that we have on every island something that says personal goals and life aspirations. In this work, it's very important for us to know what were the personal goals of the patient, when they were going through this. Did they have to change whether they were going to school or their career, or did they have to delay children or marriage? I think it's so important to keep in mind, what goals they're trying to reach, defined by themselves, and also how it interacts with their family, their social life, and their condition. You can see at the top here also are what we call life factors. You may have heard this term also as social drivers or social determinants of health. And so those are things that we think are so important that interact with the patient, and in both a positive and negative way that may affect their disease journey. This is their family and support system, work or student life, housing, transportation, their general healthcare quality and coordination of different conditions they may have, their insurance and how easily they're able to access care, mental health, emotional health, other conditions, and then finances and other costs. We know these are really important to talk about. So throughout the interview guide, we do ask questions about all of these. And then finally, the next slide shows how the map is used in conjunction with the interview guide. This is just a little slice so you can see what it would look like. You can see here on the left-hand side, we have the third island, living with the condition, and then a piece of the interview guide that shows what living with a diagnosis means when we interview them about trying a treatment. So this is a section where we ask about any treatments that they take. This can include both pharmaceutical, stress relief, acupuncture if they did that, And it kind of runs the gamut, even clinical trials, genetic testing, all of that. So really getting into the depth of their perceptions on what it was like to go through that treatment, side effects, reasons why they stopped it due to finances and everything like that. So I'm now going to turn it over to my colleague Lillian Whitting, who's going to describe a little bit more about the current study and how we use this methodology and adapted it to the kidney disease community. Lillian?
Thank you so much, Silka. I think you can move on to the next slide. So hello, everyone. My name is Lillian Whitting, Senior Coordinator of Research and Programs here at the National Health Council. And so I'm very excited to be working with AKF on this amazing project as we continue to build on that toolbox that Silka kind of gave an overview about and kind of talk about how we are focusing it on specific disease states. And so again, this one is specifically focusing on the lived experiences of patients with chronic kidney disease. So next slide, just to give a little more of a study overview. The objective of this was to look at how the experience beyond the clinical interactions that patients face. So, we're looking at how those life factors that Silka mentioned, how they can affect diagnosis, what resources are available, and how treatments can affect other aspects of life beyond just the clinic. And so the kidney disease, we're looking at vulnerable populations. And so this was a sponsored project, and our focus was along populations for Black and African Americans, Hispanic and Latino, and Asian Americans. And so we also recognize that CKD can often occur alongside other rare conditions and comorbidities. And so we also were able to recruit various patients who had both general CKD and those with rare conditions that I will mention later on. So some other goals of this project is to look at the disease progression alongside chronic diseases and other rare conditions. So we're ensuring that we can identify gaps in care and identify life factors that really matter to the patients. So we are asking the patients what they want to see and what they experience and how we can address those concerns. And so we're also looking at the state of research and how the science can improve. So how treatments affect, are there other preferences for different kinds of treatment? And we're also looking at the differences in experience for various populations. Again, we have focusing on 3 main populations, but we have patients from around the USA. So moving on to the next slide to talk a little bit more about a methodology and how this came about. And so again, we want to emphasize that we're working with those within the community to ensure that we have the expertise from patients and other people in there. So our project was guided by a steering committee made up of patients and patient organizations, researchers and clinicians. And so they were instrumental in determining how and what questions were asked and editing the interview guide that Silka showed, and to really tailor it to the CKD experience and ensure that the guide was culturally competent when we asked these questions. And so we worked with the AKF staff as well to help recruitment across the United States. And as you can see in the recruitment table below, we recruited within 2 different cohorts. So the first you can see is with patients living with general CKD, and the second is focused on additional diagnosis of a rare disease. And so this includes APOL1, IgA nephropathy, lupus nephritis, and a couple more. And so we wanted to ensure that we had a wide variety of experiences and that we could look at some common themes that were identified between interviews. And so we broke that up into the two different cohorts. And so these 60-minute interviews were conducted by both us and AKF staff. And so these interviews were then analyzed, and again, looking at general themes to ensure that we know what patients are interested in. So going to the next slide a bit to talk about some of the common themes that we've been able to pull from the almost 60 interviews that we have. So we were able to look at some of talk about the early symptoms. And so a lot of patients mentioned these symptoms that you can see up here. And as well as sometimes, although symptoms may not have shown up, when they did show up acute, or when they showed up very quickly, then it sometimes prompted patients to either seek or receive emergency care. And then when we were talking about diagnosis, especially the experience of getting diagnosed, there were quite a few that talked about having a lack of information. They felt like they did not have a strong understanding of what to expect, either during the diagnostic exams and biopsies, and sometimes especially being health literate. And so ensuring that patients can understand what the next steps are, and especially what that means for them, and for how their life goals are or will affect that. So, when Silke talked about them talking about their life goals, we asked them questions, and how diagnosis changed that. And so that's kind of what we found. And so we also asked some questions specifically about relationships with providers. This can be with both the primary care physician as well as specialists, including nephrologists. And so when we talk to patients about their experience with it, a lot of them mentioned that they would like to have more empathetic communication, and have more time building personal connections with their providers. So to, again, ensure that they're comfortable with asking the right questions, or comfortable with moving on to the next steps. And so there were also suggestions for more health literate communication to patients. And so this was, again, focused on the nephrologist specifically, because there can be a lot of scientific jargon and language that can be difficult to understand, and especially with the shock of receiving a diagnosis. There has to be some time to be able to understand what's happening. So moving on to other early common themes. So when we were asking questions about treatments, this often revolved around dialysis. And so the two common mentions were peritoneal versus hemodialysis. And so a lot of patients had different lifestyles, and sometimes they were able to talk to their providers about which options could work for them. But they had, different things going on. Some of them had sanitation concerns. Some people had pets, so they wouldn't be able to do dialysis at home, so they would have to go to a clinic, as well as for some people, it was difficult to get to a clinic, so it was easier to do dialysis at home. And there was also need for more information on eligibility for transplant. And so there were several people who were on the wait list for transplant, or who had already received a transplant. And so many times there was some confusion about the tests needed. And again, those next steps, what it meant to be able to get on a wait list. And some people were taken off and not told exactly why they were taken off the wait list. And so we just wanted to capture those experiences so that clinicians can have and other people can understand better what that means. And in terms of the life factors that were mentioned by Silke as well, um, some of the main themes that we pulled from here was that the mental and emotional health support, many people felt stigmatized by it and they didn't want to share that when they got their diagnosis, or they felt conscious about it. And so there was some conversation about resources to help open the discussion around diagnosis of CKD and living with CKD. And then there was also the impact on family and other social relationships. So people often talked about how their support was there for them, could help them with appointments, or if they were lacking support, and where they looked for support, and whether the diagnosis could change social relationships, because some people's lifestyles were very social, and that changed with the diagnosis. Another one is impact on career. So many people had to take a step back in terms of work, and there were others who also went on to disability. And then there was the coordination of specialty care. So as we mentioned, there can be comorbidities with CKD and other conditions. And so there was quite a bit of coordination required to talk to different specialists, to talk with primary care physicians. And so some patients felt overwhelmed or frustrated by the amount of coordination that they had to do with their specialists. Like some people even, asked all of their specialists to get into a room together, just to talk with everyone to make sure that everyone was on the right page. And so before we move on to some of the quotes, just to illustrate some of these common themes, I just want to mention, that we're still in the early phase of analysis. So these themes still are a bit subject to change, but yeah, I just wanted to emphasize that before we move to the next slide. But going to the next slide, these are some quotes just to kind of emphasize what was just said. So when we're talking about diagnosis again, people talking about doing research on their own because they did not receive the adequate enough information. There were some people who mentioned, finding info on various websites, or even going to Reddit and Google as options for learning more information about the diagnosis. And in terms of treatment, again, we have people that have pets or are able to have the equipment at their place. So again, it's just talking about tailoring of treatment, and so personalized treatment to help people live the lifestyle that they want. And then the relationship with providers, again, talking about that personal connection and being comfortable with their providers and being open to advocating for themselves. That's a huge thing, because a lot of people felt that they were, talked over, or that their voices were not heard when talking about their symptoms, or when receiving biopsies. They did not have a good experience with that because they did not have that connection. And so going on to other quotes in the next slide, we also have some talking about symptoms. And so, you have symptoms that were not always there immediately, but you had other people who progressed very slowly. And so just a variety of different experiences through that, as well as the different life factors. And so you can see how it affects people's mental health. You can see how it affects, it's affected by transportation or other things like that. And so to upkeep the privacy of the patients, all these quotes are also credited with a participant ID number. And so, yeah, this is just to illustrate a bit more about those common themes that we saw. And so in the next slide, so what are we doing with all of this information? So we have received, again, almost 60 interviews. We are going through the transcripts. We're analyzing them for common themes. And so now that once we start identifying those more thoroughly, what are we going to do with that? And so in terms of dissemination and ensuring that people understand what they can use this for, we will be publishing a project report and an infographic. And so this will just have a more in-depth look at how the methodologies that were used here, again, the common themes, some quotes to illustrate those themes, and some graphics as well to help people understand, like what symptoms were the most common. And so we're hoping that this can help inform people throughout the healthcare ecosystem, whether that be a patient, provider, payer, policymaker, anyone who is interested in, how this can affect the lives of people with CKD or who interact with the lives. It can inform them of, or they can utilize this information. And so patients can advocate for themselves. This can help direct future medication or for even treatment research. And it can help provide providers to ensure better care with an understanding of how the condition can affect various aspects of a patient's life. And we're also looking at hopefully publishing a manuscript as well and make it publicly available for anyone who is interested. And other things as well include presentations and webinars such as this one, so that we can get the word out about this amazing project and the amazing work that we are doing to ensure that the voices of patients are heard. And so with that, I will end.
Great. Thank you both for sharing all this information. We will move on to the Q&A portion of our webinar. And so if you're listening live, please go ahead and type in your questions and comments in the chat box to the right, and we'll get to as many of your questions as possible. So to start us off, I'll ask the first question here. So you mentioned during this presentation, but could either of you share in depth how the study benefits a patient?
You want me to go first, Lillian, or you want to?
Sure, yeah.
Yeah, so I think there are 3 really important points that I got out of this work after conducting a lot of the interviews and analyzing my colleagues' interviews. Is one that kidney disease is often all-encompassing on a patient's life. The patients mentioned how it can often sometimes affect every part of their day, and which I don't think is commonly understood kind of in the research or policy space. So I think just looking more into the emotional health, mental health aspects that Lillian mentioned, even having support for depression and other things like that is so important. That's something that almost nobody mentioned that they received when they were in clinical care, even after some of them did describe their diagnostic journey as traumatic. So that's something extremely important. I think there's one other thing we learned is that there's not nearly enough intervention when kidney disease is at its early stages. So another really important thing that the community can assist with, creating a more comprehensive education in the provider space, especially the places that patients go first, like the ER, urgent care, with their PCPs. And then I think something that we've mentioned several times is health literacy. Nephrology, just the space in general, is so difficult to understand. When you're in shock getting that diagnosis or hearing news, it's hard to comprehend it. And when you're just receiving a pamphlet, it's inadequate. So I think this work is important because it shows the things that patients are prioritizing as the most impactful, either in a positive or negative way, in their disease journey, and really giving us the information of how we can affect that change. So may have ranted a little there, but I think that's kind of what came out for me.
Absolutely, yeah. And just to build on Silka's point as well, through a lot of the interviews, again, we talked about resources and the sharing of information. And so I think the availability of that information, whether you have a pamphlet, but then having a more in-depth and well-informed guide in an accessible way is very important. And then finding those support groups as well. So when we talked about the life factors, you have the family support, but you also have the support of there are patient groups and patient support groups that were really instrumental for some of the interviews in understanding what those next steps were and being able to talk with other people. So that's why this work is so important, to share and to share the experiences. So those who may not have that access to support groups or do not know of them yet can look at this and get a better idea.
I think, yeah, and reinforcing that is that a lot of the questions are questions that other patients have too. So when we publish this work with, the things that educational materials that can be produced, the things that patients suggest, it'll show the patient community, one, that, a lot of their struggles are something that others are going through, maybe not understanding when they receive a diagnosis, like what the next steps are in nutrition or lifestyle changes or things like that. So that's really important. But I also just think the benefits of having that community around you are so important. So, I'm hoping in any published materials, we can link to things that say, like, here's where you can go for these, because I think there was a sense of isolation in a lot of the interviews, the sense that, like, well, people don't understand what I'm going through in my family or my life. And I wish I had somebody to talk to about this. I would say that was especially true in the rare cohort, even sometimes because they had a rare condition, their nephrologist didn't really understand what they were going through because they had the kidney disease and a rare condition.
Yeah, absolutely. Thank you both for sharing your thoughts on that. Next question here. How is a collaboration with advocacy organizations like the American Kidney Fund beneficial to improving patient care quality?
I can start this one. So as we mentioned in the methodology of especially creating this project, we wanted to ensure that the steering committee was working with experts in the field, so patient groups like the American Kidney Fund and others in research were just so valuable in being able to provide insight. Again, we had patients on the board, so we had patients looking over the questions. Again, these are questions that patients have, and so having the patient groups there to be able to help share the knowledge and, again, share all the information that's out there, because, again, sometimes people don't realize where the resources are. The internet is a very vast place, and so it can be very helpful to have those experts there to share.
Yeah, I think it's all about information, because, the patient community is so important because they can help clinicians use the details that we created to focus more on the important things that patients are saying that may not come out in a normal visit that lasts 5 or 10 minutes. What we said about mental health being of primary importance and like good information for patients is something that's often only found through patient organizations or patient support networks. Maybe that's something they can't get as part of their their clinical treatment just because the appointments are quick, or maybe there's out-of-date information. Those pamphlets aren't really talking about that. So I think it's great that patient groups like you guys are so involved, because really what we heard loud and clear is there needs to be more health literate information. The patient communities themselves and the patients can create this information and get to the topics that are of primary importance, and not just, beyond side effects and treatments, but their social lives. And as I mentioned before, nutrition being really important and things like that. I think patients often seek care in kidney clinics that are specialized. So the clinical staff would probably highly benefit from, working with patient organizations just to get that better information out there, and accompanying mental health services or referrals, and things like that. So just can't overstate enough the importance of you all and your role, both in research and providing that day-to-day hope for your constituency.
Thank you. Yeah, we definitely like to work with patients in all of the projects that we do, making sure we create our patient-centered, because there's only so much we can say as far as how to support people, but really hearing from them is how to create the best helpful information. What practical steps can healthcare providers and patients take to implement the insights gained from this study in their clinical interactions?
I think that there is clearly a need for more information in this space. That's just something that kept coming up, both diagnosis-wise, what the next steps were, treatment, what your life is going to look like. So I think this can show from a firsthand account things that clinicians are not going to learn through their normal mechanisms of monitoring quality care practices. I've seen some of the surveys that patients often get asked after ER visits and things like that, and they don't ask questions like the questions that are asked through these qualitative studies. They're focusing on, like, do you trust the doctor or nurse that gave you care? Did you feel that your care was adequate, and things like that. It doesn't say, like, do you feel like you got enough information? Do you know where to go next? Do you know what you need to change in your life, or things like that? Or do you feel like you're in a safe space, mentally or emotionally? There are some patients that mentioned that they didn't really have any family support. I think one of the quotes Lillian brought up was a patient who mentioned that they had an invisible illness and how hard it is to live with an invisible illness. So even support for what they can tell their families, what they can tell people around them. I know there's certainly a lot of stigma also. So I think these expectations can kind of just, it feels like you're getting hit in the face. A lot of patients use words like, I was totally, like, I feel like somebody hit me when I got my diagnosis. And, so we think we can all work together, especially with the clinicians, to make that process a little bit easier, as easy as we can.
I agree with that. And as well as just the provider education and clinician education. We're looking at providers who are just asking the regular questions during, again, 5 to 10 minutes. You don't really get an opportunity to talk, or you feel so shell-shocked that you can't ask a question. Clinicians may not be focusing on the patient themselves, because there is a lot going on at a clinic. This information can help clinicians understand that patients want a little more focus on their emotional health, or maybe they realize they're shell-shocked, and so they can take a moment to pause, ask if they do have questions, things like that.
And we know the clinicians are very overworked and often have to do a lot of administrative reporting. So definitely this isn't a, clinicians need to change everything about the system. I think we need to create a system that's better for everyone, and that includes people who are providing care, so that they have the best opportunity to build a trusted relationship with patients. The relationship with the provider was, I think, one of the most important things that we heard, and so important. And I think another thing that came out, and which was mentioned in some of the early results was that some providers did miss cues that a patient was struggling with chronic kidney disease, whether they be PCPs or in the ER. Some patients mentioned actually that they tested themselves because they knew about kidney disease in their family. So they tested themselves because they weren't getting the care they needed. So I think not only an awareness of the seriousness of chronic kidney disease, but also once a patient is in the system and is diagnosed, how can you work with them to reach the goals that they want and make sure that you both have a trusted relationship that's not, that has communication that goes in both directions. I think breaking down the hierarchy is especially really important.
Yeah, absolutely. Thank you both for sharing. And I think like a reminder too to patients to be their own advocates, can expect your provider to be able to do all these things for you and being able to voice if you're not getting the care that you expect, or seeking other providers too if the one that you're seeing isn't meeting your needs.
Yeah, I think the patients that we spoke with, I think, they're all heroes. Like they're really brave in the things they went through. And so I think, for patients, just keep doing what you're doing, being part of research and speaking up when you see something wrong in the healthcare system. A lot of us are working, trying to find ways to improve you and your family's lives, but we can't do it without the leadership of the patient community.
Absolutely. So how could a patient get involved or learn more about this study?
So this specific study, again, we are hoping during the dissemination to share all of this information on our website eventually. And so, you can keep up to date on the National Health Council website, as well as we will be posting announcements about the publication of our potential manuscript. And we'll also be sharing with our partners, the American Kidney Fund, to help spread the word about this information so that patients can have access to it.
Great, thank you. And then I'll just ask one last question to wrap it up here. What key takeaways would you like patients to walk away from today's session?
I think take care of your mental and emotional health, as well as your physical health. I know it's really hard when you're, in the depths of dealing with your diagnosis and your treatment and going through so much. It's so important. I think it's also good for patients to know there is a community out there. There's a community of researchers, policymakers, other patients, caregivers, that are all working towards the same goal. And there's a lot of support out there. It's hard to find it sometimes, as Lillian said, you have to parse out the noise when you're like on the internet or in Facebook groups and stuff. But, we are out here. And of course, the American Kidney Fund is out there. So I hope that patients reach out and continue to, both assist us with research as leaders, but also, make sure they kind of ring the bell and say when something's wrong, or say when they think we need to change something in the system.
I couldn't have said better, as we have mentioned multiple times within this, just advocate for yourself. And we understand that it can be hard. Again, the interviewees that we've had are incredibly brave for being able to speak about it, because again, there was a lot of mention of stigma, a lot of fear of, being able to share this, what's happening to them. And so we're incredibly honored to be able to work with patients who are open to talking about it and being willing to share their stories to ensure that other patients can advocate for themselves.
Great. Thank you both. And if you have any questions about the Patient Experience Mapping Project, feel free to visit or send an email through the National Health Council website. And again, that's nationalhealthcouncil.org. And on behalf of the American Kidney Fund and National Health Council, I'd like to say thank you to our audience for joining us during this session. That's it for today. So tomorrow, tune in for a live Q&A workshop starting at 10 a.m. Eastern Time. You can follow us on Facebook or send an email through kidneyfund.org to find out more resources like this. And once we conclude this session, you'll see a link for a quick survey in the chat. Please take a minute to fill it out and tell us how we did. Your feedback is very helpful as we plan future sessions like this. Thank you, everyone, and have a great day.